coughing. So you have to do some special testing to figure out what the cause of the cough is, and sometimes it's just asthma. So you also mentioned COPD. COPD is actually two different diseases. Both chronic bronchitis and emphysema fall under the rubric of COPD. And the most common early signs of COPD are cough and shortness of breath. And then I think you also said lung cancer. Lung cancer very early on can be asymptomatic. You don't know you have lung cancer, but when it begins to manifest symptoms, the most common things you see are cough and weight loss. And then as the lung cancer advances, and particularly if it invades the airway, patients can have what we call hemoptysis, and that is bleeding when you cough. So bloody phlegm or bloody sputum associated with cough. Those are the common signs of lung cancer, early signs: cough, hemoptysis, and weight loss.
And when mentioning lung cancer, I remember this one thing that you mentioned when we came to our program. You said that lung cancer can almost be completely prevented by just not smoking. Can you elaborate on that for the audience and maybe tell us what the almost excludes?
So you just said the most important thing, which is that if you don't smoke, you won't get lung cancer. And that accounts for 95% or more of lung cancer. The other 5% of lung cancer is, first of all, somebody else smoking. So my parents were big smokers. I hope that didn't affect me, but it can cause lung disease in people around them. That's called secondhand smoke. So secondhand smoke can cause lung cancer. And then the other very common cause of lung cancer is noxious gas. I'm blanking on the gas that arises from the earth. I'm blanking on the name of the gas, but noxious gases arising from the earth. In Pennsylvania, they're very common and have to be tested for whenever you buy or sell a house. So that's the other two things: noxious gas and secondhand smoke. But by far, the most common and the most important cause of lung cancer is smoking. And if you don't smoke, you probably won't get lung cancer.
Mm-hmm. I think some people in the chat, they said radon. Is that?
Yes, I'm sorry. That's it. Radon. Yeah, that's it.
So we also had a question on that same note. Someone asked, what are the effects of secondhand smoke, and can a family history of smoking be a detriment to your health?
Not only can it often is. So I never smoked. My parents, my dad was an ophthalmologist, an eye doctor, smoked 3 or 4 packs of cigarettes a day. He couldn't smoke in the office. He couldn't smoke in the operating room. So where did he smoke? At home. And I got asthma as a young man. I was in my teens, probably very likely related to my father smoking. My mother smoked some as well. So yes, secondhand smoke can cause lung disease like asthma. It can worsen existing lung disease, like if you have somebody in the house who has cystic fibrosis or asthma and somebody else is smoking, will definitely make those worse. And it can contribute to other diseases besides lung disease as well, like heart disease. So it's a very well-known risk factor for those.
So let's say that your parents smoked before you were born. Would that have any effect on you growing up or with your lung health, possibly?
So if they continued to smoke after I was born, for sure. If for some reason my birth convinced them to stop smoking, it would certainly affect their health, but it would not directly affect my health if I wasn't exposed to the smoke. No.
Okay. On the same topic of smoking, someone also asked, how does smoking affect the lungs, and what happens to the lung after you quit smoking?
So that's a really good question, and it's one of the things that's been a topic of study for the last 15 or 20 years. So smoking causes both lung cancer and emphysema, and it also makes other lung diseases worse. For example, people with asthma are made worse by smoking, and smoking can contribute to the risk factors for other cancers. But how does smoking do that is the most interesting thing, and I think that's what you're asking about, so I'll try to answer them. So it causes lung cancer because there are carcinogens in cigarette smoke. There are particulates and chemicals in cigarette smoking that themselves directly cause cancer. The other interesting question is, how does smoking cause emphysema or COPD? And that has a two-part answer, two-part, very interesting answer. So smoke is an irritant. It attracts white blood cells and inflammation to the lung. And those white cells in the lung release toxic substances called proteases, which can damage the lung. But the other thing that smoking does is it inactivates antiproteases. There are molecules in the lung that protect the lung from the proteases released by those white cells, but smoke inactivates those antiproteases that allow the proteases to be unopposed and do damage to the lung. And then I think you asked about quitting smoking. If you quit smoking, so your lung function tends to get worse with age. That's more true if you smoke. If you stop smoking, your lung function will decline more slowly, but it never returns to normal. And stopping smoking also decreases your risk of lung cancer, but it always remains higher than someone who never smoked. I hope that answered the question.
Yeah, thank you so much. We also have quite a few questions talking about like other like non-smoking issues. For example, like someone asked like how much is dust allergy and like how could that affect lung health?
Okay, so not all allergies affect the lung. They may or may not affect the lung. When they do, the most common symptoms of allergies affecting the lung are cough and wheezing and asthma. So one form of dust allergy is allergy to dust mites. These are little bugs, literally little insects, tiny little insects in dust, and people become allergic to those, and those can cause lung and ear, nose, and throat problems. So the most common causes are things that they cause are rhinitis. Rhinitis is nasal congestion and an itchy, runny nose, but they also cause skin problems like eczema, and they cause asthma too. That's the way that most allergies affect the lung. They cause asthma, or they make someone's pre-existing asthma worse.
So how can something cause asthma? How does that work?
The asthma is usually an allergic, not always, because there are other causes as well. But when it's caused by something like dust, it's usually an allergic response to a protein molecule in the environment. So again, the dust mite, for example. Those dust mites attract inflammatory cells. The inflammatory cells release substances that make you wheeze, that cause your airways to narrow. And that's how most things that cause asthma, that are protein molecules, allergens, cause asthma. There are other types of asthma that are not related to protein molecules and allergens. For example, cold weather. A lot of people have cold-induced asthma. Some of you out there may have exercise-induced asthma. That's my form of asthma. If I would run on a cold day or play basketball outdoors on a cold day, there's a whole other mechanism for how that type of exposure can cause asthma. But in most people, it's an allergic reaction.
So someone also similarly asked, like, how does air pollution, is that like similar to what you just explained about dust mites and stuff? And they also asked, like, what are some steps that we could take to minimize the impact of air pollution on lung health? So
most air pollution itself there is not an allergic response to air pollution, but there are chemicals and particulate matter in dirty air and smog that are difficult for people with pre-existing lung disease. And it's particularly worse in people with things like asthma and COPD, who are already short of breath and already have difficulty breathing. And the best thing you can do is to avoid exposure. So, for example, not living in cities, which might be difficult to do if you live in a city, but also remaining indoors on days when there's lots of smog or very high air pollution indices. So it's not exactly the same thing as an allergic response or an asthmatic response, but it can be difficult for people who have asthma and emphysema.
So another person also asked, like, what causes seasonal allergies and like what we could do to prevent them? Because I know they're much more common than like other allergies that people might have. It seems like everyone has like pollen allergies and stuff like that. So is there anything like?
So most seasonal allergies are something in the environment that is seasonal. So like pollen, like dander on certain animals that tend to shed at certain times of the year, like particular trees, flowers, pollen, leaves, that shed a particular time of year. I'm not an allergist, so I don't know that much about it, but just to say that most seasonal allergies are environmental factors that appear in certain seasons. And the best example is pollen.
So, like you said, like being in the city, there's much more like kind of risk factor for lung health. Do you have like any memorable case that you've seen in your time and something you've learned from that?
About living in a city?
Not exactly. It could be anything, but just a memorable case that you've seen as a pulmonologist.
I was buying my wife a birthday present, and we were living in Wilmington, Delaware at the time. I was buying my wife a birthday present, and I went to a leather shop in the city, and the guy selling the belts, I was going to buy her a belt, was also the guy who made the belts and the bags. And as he was talking to me, he was sneezing and wheezing, and his eyes were running, and he kept wiping his nose. And I started talking to him about it, and he said this was something that had come on in the last few months. He'd been running this shop for a long time, but now every time he came to the shop, he would have these symptoms of runny nose and wheezing and shortness of breath. And it was sometimes worse, not when he first got to the shop, but when he had been there for an hour or two. And we talked about it for a while, and I had him come in for testing, and he had developed a leather allergy. So when he was cutting leather, when he was preparing leather to make a belt or to make a handbag, it would aerosolize dust from the leather, and he had developed an allergy, and he actually had to give up the shop. He had to sell the shop. We tried treating him with steroids and trying to avoid the leather, wearing masks and things like that, but just nothing would work for him. And he eventually had to give up the shop and had to change but actually, I think he sold it to a relative and maintained a connection, but wasn't able to work with leather after that.
That actually brings us to another question that we have. Are there any like specific like occupational hazards that might pose like a risk to lung health?
So there are some very famous occupational connections to lung health. The most famous one you probably know of, and that is asbestos exposure. So in the past, asbestos was used to create brake linings, to line the boilers on ships, on naval ships. It was also used just for insulation in buildings. And people who worked with asbestos, even if they had single brief exposure to asbestos, could develop what was called asbestosis, 5 or 10 or 15 years later. This is a lung disease that causes inflammation in the lung and shortness of breath. But even more devastating was they would get 20 or 30 years after working with asbestos, they would get a very severe and almost untreatable type of lung cancer called mesothelioma. Now, the use of asbestos in construction, like I was mentioning, hasn't been done now for years. They haven't used it since the 1970s or 80s, but there are still people developing asbestosis and lung cancer because they used asbestos in their work in the 1970s or 1980s. And now 30, 40, 50 years later, often as older men, it's usually older men, they're developing this type of lung cancer. Now, in addition, there are other famous associations. Coal mining, for instance, and construction work can cause a disease called silicosis. There's a metal that's used in aircraft manufacture called beryllium. You may have heard of it. And beryllium exposure, if you grind beryllium, causes a disease called berylliosis, which is very similar to another disease called sarcoidosis. And then, just like I mentioned, there are diseases where you work with dusts or organic material that can cause asthma or asthma-like diseases, or another type of disease called hypersensitivity lung disease. The best examples of that, the most famous are farmers. Farmers get farmer's lung from exposure to certain mites and fungi in the silage, in the collected crops that they stored. Leather workers, bird handlers, all get certain types of lung disease from exposure to the dusts and other protein material. And then, of course, if you have asthma, there are occupations where you can be exposed to things that will trigger your asthma, like dust or allergens or cold or certain chemicals, and those can be very dangerous.
Sorry. When these patients come into you, what tests do you use to diagnose these conditions?
So the two most common tests that pulmonologists use are chest x-rays, just a plain x-ray of the chest, and a suite of diseases of tests called pulmonary function tests. Those are the two most common things we do. Chest x-rays very commonly, pulmonary function tests a little bit less commonly. And then depending on the disease in question, there are other tests you might do. And the famous ones there are CAT scans, for example, to diagnose cancer, diagnose lung cancer. And then a common test that I do and that most pulmonologists do is called bronchoscopy. And that is placing a fiber optic scope with a camera on it into the lung to examine the internal lung. And we can do other things through the scope too. We can get biopsies, cut out small pieces of things. So those are the most common tests.
So in my A&P class, they once mentioned like spirometry, and can you explain a little bit about that test?
Sure. So I had just mentioned pulmonary function tests. One of the pulmonary function tests that we do is called spirometry. Spirometry is having the patient breathe into a machine, and while the patient is breathing, we do certain maneuvers, like have him breathe fast or have him breathe deep. And then we measure the timing of his breathing, how quickly he can get the gas out, the volume of air out, the volume of his breathing, how much gas he can move over how much time, and how completely he can empty his lung. And different diseases like asthma or emphysema or interstitial lung diseases of older people or pneumonia show different spirometric patterns. So you can actually diagnose a disease or help diagnose a disease by looking at the pattern on spirometry. And it may not give you a complete answer, but it gives you a partial answer. And the other thing you can do is, if you're treating the disease, if the patient has asthma, for instance, and the spirometry is poor, you try certain medications. And of course, you ask him how he feels. And if he feels better, that's good news. But you also repeat his spirometry. And if the spirometry is improving and the patient is improving, then you have some idea that what you're doing is the right thing. And if it isn't working, then you might try some other medications or other maneuvers to treat the patient.
So what about when it comes to any like chronic respiratory diseases? Are there any like newer advancements in like treating those, or have you seen in recent times?
So there's always research going on into lung disease. So the most famous of these newer advancements is that for some diseases, and I'll just name a few, for diseases like cystic fibrosis, for severe emphysema, for a disease called pulmonary hypertension, and a couple of other diseases, you can transplant the lung. Lung transplantation is a real option. It's not the cure-all. People with lung transplantation have problems for the rest of their lives because of the drugs that they have to take to avoid rejection. But it's better to have the lung transplant and those problems than to be dying from cystic fibrosis or emphysema. So that's one example of an advancement. Just for a couple of others that I was thinking of, for people with asthma, there's now a treatment for severe asthma. There's now a treatment called bronchial thermoplasty. And in thermoplasty, what we do is, I mentioned that fiber optic scope that we put down the lung to look around. You fit the end of the scope with a heating element, and you create superficial burns on the inside of the airway that damage the muscle of the airway that constricts when a patient has asthma. So then if they get exposed to whatever exposes them, whatever triggers their asthma, the smooth muscle that would normally contract the airway is damaged and can't contract. And that blunts the effect of that trigger on their asthma. So it's a very tricky thing to do. You can imagine that burning the inside of the lung is not a safe thing to do. It has to be done very carefully. But in select patients, it can be done. Yeah, go ahead.
No, go on.
So I was going to say just a couple of other things. So for patients with emphysema or COPD, there's now gene therapy or replacement therapy for those anti-proteases that I mentioned that are either missing or are damaged by smoke. So you can actually create new genes in the lungs of some patient, or give the patient proteases and protect them from the protease attack and protect them from the threat of emphysema or COPD. And then the last one I would mention is that there are new types, there are certain types of lung cancer where the lung cancer itself is associated with a gene mutation. And we now have drugs that specifically target a gene mutation. And instead of giving the chemotherapy or the immunotherapy that we treat most lung cancer patients with, they're treated with these new targeted drug treatments, and they have much better response rates and cure rates than for typical lung cancer. Those are just a few of the newer ways of treating lung diseases, chronic lung diseases.
So you mentioned like lung transplantation. So I remember when I came to your program, like one of the surgeries that we watched, it was actually like it wasn't lung transplantation, but they like removed one of the lobes of the lung. So can you kind of explain to the participants like the different lobes of the lung and if what we can live with, what we need to live with?
So the right lung has 3 lobes, the left lung has 2 lobes, and you can definitely get along without a lobe in either lung, and you can actually get along without an entire lung. There are people who have had entire lungs removed either because of trauma to the lung or cancer in the lung. Removal of the entire lung is the most common treatment for cancer, and you can compensate. You can adjust the blood flow to the remaining lung, you can adjust your lifestyle, and you can actually compensate and do very well. If you're asking me what's the minimum amount of lung you can live with, I'm not sure about that, but I have seen patients who have had an entire lung removed and the lobe of another lung removed, and who continue to they live. They're not the most comfortable people in the world. They often need oxygen or other therapies, but you can live with less than 1 lung.
So also kind of going back to my EMT class, we learned about like instances where obviously oxygen is a drug. So like we learned about instances where like too much oxygen can also be a bad thing. Can you explain a little bit about that?
Yeah, so there's a condition, a lung condition called ARDS. It was actually described for the first time during the Vietnamese War, during the Vietnam War, where certain types of trauma can cause lung disease, even if it's not trauma to the lung. So if you need a blood transfusion, if you have a crush injury to your leg, no one knows why, but these kinds of injuries would release substances that would damage the lung. So I'm sorry, could you repeat the question? Because I got off track there for a second.
No, it's okay. So we learned about like instances where too much oxygen can just be as detrimental.
So it turns out that oxygen itself can cause that type of disease. It can cause ARDS. ARDS is adult respiratory distress syndrome. Just like trauma, just like blood transfusion can cause ARDS, oxygen itself can cause ARDS. And so one of the things we learned about for ICU patients is that when you have a patient with low oxygen, instead of giving them 100% oxygen, which is what we used to do in the past, we try to give them just as much oxygen as it takes to make their oxygen not quite normal, but enough so that they can live or walk around or get around. So it's actually well known now that oxygen itself injures the lung, causes inflammation in the lung. And so when you give people oxygen, you don't just give them 100% oxygen, you give them whatever little bit of oxygen is enough to improve their symptoms. I hope that answers what you were asking.
Mm-hmm. Yeah, thank you. So we also have quite a few questions like regarding COVID.
Yeah.
So the first question asks like how effective have like COVID vaccines been at actually like preventing severe like respiratory issues?
So that seems to be exactly what COVID vaccines do. They prevent severe respiratory disease. And it's especially true in people who are at high risk. So for example, older people over 65 or 70, or people with immunocompromising illnesses like cancer, but other immunocompromising illnesses like diabetes as well. And so in some populations of people, the protection of the vaccine from getting COVID itself is modest. It improves, fewer people who have gotten the vaccine get COVID. But the real advantage to the vaccine is that they protect from severe disease related to COVID. Not so much from COVID itself, but from severe disease related to COVID. That's exactly what the vaccines do.
So what are some like long-term effects of COVID, like on lung health?
I had a feeling you were going to ask that. That's a great question. And the answer is that we really don't know. There is this entity of long COVID. And long COVID is usually persistent symptoms related to COVID infection. It may or may not affect the lungs. I have a friend with long COVID. It doesn't affect her lungs. It makes her tired. She's just always tired, has trouble walking around, taking a walk around the block. But if it does affect the lung, it often causes cough and shortness of breath. It can cause this fatigue that my friend has. And these symptoms of long COVID, they're very hard to treat because the patient typically no longer has the COVID virus. So antibiotics or drugs against the COVID virus are not helpful. And we really don't know how to treat these people. There's some exercise training that's used, some drugs like steroids have been tried, but we don't know what the exact cause is, and we don't know how long the symptoms last. So the answer to your question is we don't really know. We don't really know.
So coming back to like kind of the research aspect of COVID, I know like working at UPenn, like that's kind of where like a lot of research behind the vaccine was like started. So how was that like right behind the scenes of the midst of the COVID pandemic and just like in the midst of it all and creating the vaccine also at where you work? Like, can you kind of explain that experience?
I don't know much about the research aspects of COVID. Now, you guys may know, and I think, Priyanka, when you were there, did you tour the Weissman lab? The Weissman lab is the lab at Penn that helped develop the mRNA technology. Did you have a chance to tour that lab?
There was multiple groups, but unfortunately, like I wasn't one of the groups that toured that lab specifically. But I do know that they came in and made a little presentation about actually creating the vaccine and the science behind that. Yeah.
So I don't know much about it either, but although the vaccine itself was developed by these two companies, Pfizer and the other company, the technology for using mRNA, so most vaccines are proteins. You inject a protein, the protein causes an immunogenic reaction, and then you either give the antibody that's developed, or sometimes you actually give the protein, you give the antigen that's developed. They developed an entirely different approach to vaccine making, and that was using mRNA. I wasn't involved. I don't know much else about it. Now, there were other studies of the COVID vaccine, several of the COVID vaccines that went on at Penn. I don't know much about those. I wasn't involved.
I understand. Thank you, though. Another question we actually have regarding COVID-19 is someone asked how to control like phlegm and like congestion for patients that have recovered from COVID-19, and is it possibly dangerous?
Yeah, so that's a common problem after almost any pneumonia, not just COVID. So COVID is really a pneumonia. It's a viral pneumonia. And patients after viral pneumonias or recovering after pneumonias often have cough and phlegm. And they're very hard to treat. There were some drugs that were being developed for treating the phlegm, the productive cough. They don't work well, and they had major toxicities. So although there are drugs now for treating cough, there aren't great drugs for treating phlegm, for treating secretions in any kind of patients, not just COVID patients. There are a few drugs like atropine or homologs or analogs of atropine that can be used, but they have a lot of dangerous side effects. So there's an opportunity for a young scientist, an anti-secretory drug that treats phlegm or secretions after an infection, after pneumonia. We don't have good drugs for those kind of things.
So when we talk about cough, I know like a lot of people say like a wet cough versus like a dry cough. Can you explain the difference between the two and maybe like what the two could indicate?
Yeah, sure. So we talk about productive cough and non-productive cough. So productive cough means not only a cough, but phlegm. And the phlegm sometimes is white or yellow or green. And the quality of the cough and the quality of the phlegm are clues to what's causing the infection. So for example, a cough with green or yellow phlegm is typically a bacterial infection. Pneumococcal pneumonia, the most famous of all the pneumonias, usually causes a cough with yellow or green phlegm. Then there are coughs with clear phlegm, we call it sputum. And those are usually viral pneumonias. There are pneumonias very similar to pneumococcal pneumonia, the famous pneumonia, but they don't cause high fever or they don't cause pus in the lung. And they're also very hard to treat. Those are usually viral pneumonias, and COVID is the best example of that. Influenza is another viral pneumonia. And then there are coughs that are non-productive. So non-productive cough, it has a long, what we call a differential diagnosis. Many different things can cause non-productive cough. We talked about asthma. Asthma can cause non-productive cough. Postnasal drip can cause non-productive cough. GERD, gastroesophageal reflux, can cause it. Certain drugs can cause non-productive cough. So the quality of the cough and whether or not there is phlegm or sputum can be a clue to what the cause of the cough is. It's usually not going to give you a complete answer, but it's a clue, and different diseases cause different patterns of cough.
So for those, for people that may not know, can you kind of explain what the different kind of lung conditions might mean, like cystic fibrosis, COPD? I think you talked a little bit about that, but pulmonary hypertension, I'm sure there's a lot of people that have heard of cystic fibrosis and stuff, but maybe not know exactly what it is.
So I'll just run down a few common ones. So you mentioned cystic fibrosis. Cystic fibrosis is a genetic disease. It's probably the most common genetic disease in white people, less common in Asians, less common in Chinese, for example, almost unheard of in Chinese. It's less common in Black people. But among white people, and particularly, just to give you an example, in the United States, it's probably the most common genetic respiratory disease. And what it does is it causes, it's an abnormality of a protein in the cells lining the lung that help you produce and cough out phlegm. So patients with cystic fibrosis can't cough out the phlegm. The phlegm is so sticky that it tends to remain in the lung, cause irritation and inflammation. And just in the last few years, and so the treatment traditionally has been lung physiotherapy. Clap people on the back, get them to encourage coughing, get the phlegm out. And that was somewhat helpful. But in the last few years, I'd say the last 10, 15, 20 years, there have been newer drugs and newer therapies to the point where, just to give you an example, when I was in training, we never saw an adult with cystic fibrosis. It was always kids, because people with cystic fibrosis tended to die very early. And then about 20 years ago, for the first time, I had a patient who was a doctor with cystic fibrosis, a young woman who was a doctor. And the drugs that had been developed and the ways of treating cystic fibrosis had come such a long way that she was in her 30s at the time. She was a pediatrician. She had her own patients with cystic fibrosis. And now in the last 5 or 10 years, there are even better drugs. There's actually, there's a gene therapy for cystic fibrosis that can reverse, or at least partially reverse, the genetic abnormality of cystic fibrosis. And there are some other drugs that can loosen or thin the phlegm, the secretions of patients with cystic fibrosis. And there are now patients with cystic fibrosis reaching adulthood. I've seen 30, 40, 50-year-old patients. I think there was a 60-year-old patient with cystic fibrosis relatively recently at Penn. So that's one example. Which other diseases were you interested in?
Like pulmonary hypertension.
So pulmonary hypertension is literally what it sounds like. It's high blood pressure in the pulmonary circulation. So the body has two sets of circulations, the systemic circulation and the pulmonary circulation. The lungs and heart have their own arteries and veins between them that are distinct from the system that supplies the rest of the body. So you can have high blood pressure in your systemic arteries and veins. That's what we call high blood pressure, but you can also have pulmonary hypertension. And people with pulmonary hypertension, there are several causes. Certain drugs can do it. Certain other conditions can do it related to AIDS, for example. COVID can cause pulmonary hypertension, and it can be a very deadly disease. And there are now specific drugs for it that weren't around even 10, 15 years ago that are very effective. And when they're not effective, and all we're treating here is high blood pressure in the pulmonary circulation. And when the drugs don't work, you can now try transplanting patients with pulmonary hypertension, lung transplant for them, and it can be very effective. It's still a deadly disease, but it's easier to treat now than it was even 5 or 10 years ago.
So about a specific disease, someone asked, like, how can we save patients with pulmonary embolisms and prevent the accumulation of fluid in the lungs in the first place?
So pulmonary embolism means a blood clot in the lung. It's a very common thing that happens in hospitalized patients. People after surgery tend to get pulmonary embolisms. People who are just lying in bed for a long time. If you're in the hospital for pneumonia or for cancer or for whatever, and you don't move around, you tend to get blood clots. They start in the leg, they move to the lung, and they can be devastating. You can die from a blood clot in the lung. It actually blocks the passage of blood through the lung. So what can be done? The most common thing that's done in these kinds of cases is people at high risk, people who are bedridden or who have clotting abnormalities or who are otherwise, or who have just had surgery, who are otherwise at risk for blood clots, for pulmonary embolism, get put on heparin or blood thinners of some kind, sometimes just aspirin. And that, if you did that to everybody who was at risk, you would greatly reduce the incidence of pulmonary embolism. So we do that in the hospital. It's often not done to patients who are sick and bedridden outside the hospital, but in the hospital, we try to do it. Now, what if you fail? What if you didn't do it and the patient gets a blood clot or gets a pulmonary embolism? In the past, the only treatment for that used to be blood thinners, like heparin or like Coumadin. Coumadin is literally rat poison, but it thins the blood and prevents clotting, and that's the way we used to treat people with pulmonary embolism. Now, there's a whole new class of drugs that are called, you may have heard them called clot busters. They actually dissolve clots. So we can take a patient who's almost dying. I actually had the opportunity to treat a patient who was dying from a pulmonary embolus. We recognized it within a half an hour of the time the patient hit the ICU, treated him with a clot buster, and he not only lived, he was out of the hospital in 48 hours. So these can be real miracle drugs in certain situations. They're similar to the drugs that are now used for stroke and for heart attack, where in stroke there's a blood clot in the brain, in heart attack there's a blood clot in the lungs. I'm sorry, in the heart. But we use them for blood clots in the lungs, and they can be life-saving drugs.
So when you bring up like the heart, obviously like they're physically very close, and also they are very connected. So how is like heart health and lung health like correlated? Can you go on?
That's a tough question. So lung diseases definitely affect the heart. So for example, I'm trying to think of one, but people with emphysema, actually people with low blood oxygen for any reason, the low blood oxygen from the lung disease affects the heart. It makes the heart pump harder. It makes it more difficult for blood to get from the lung to the heart and from the heart back to the lungs. And so conversely, people with lung disease, the lung disease can back up into, I'm sorry, with heart disease, the heart disease can back up into the lung. So if you have mitral valve disease or heart failure or a heart attack, and the heart fails, the pressure in the heart actually backs up into the lungs and causes lung disease. I'm not sure how better to explain it other than to say that the heart depends on the lungs depend on the heart, and when one fails, the other tends to go right behind it. Not always, but heart disease almost always, if it's bad enough, affects the lungs. Lung disease, if it's bad enough, can affect the heart.
So kind of on that similar line, like can stress like have an impact on lung health?
So by that you mean like psychological stress?
Yes, yeah. Mm-hmm.
Yeah, that's an interesting question. I guess I would say, I'm trying to think of an example. All right, so certain lung diseases, and the best examples of this are asthma, for example. Psychological stress clearly makes asthma worse. In fact, it's well known that patients with asthma who have psychological stress, an argument at home or something like that, and a teenager with asthma can definitely trigger an asthma attack. It's also true in emphysema. So certain lung conditions seem to be clearly worsened by psychological stress. Best examples are asthma and emphysema. But it's also interesting that not only does stress trigger asthma and emphysema, but asthma and emphysema themselves are well known to cause stress and to cause depression. So not only does stress affect the risk for asthma and emphysema, but asthma and emphysema affect the risk for depression and psychiatric illness and psychological stress itself. It's the best I can do.
So like, how does like kind of like your lifestyle, diet, or nutrition, or maybe like your exercise, can that like help to maintain a normal like and healthy lung, I guess?
So I'll talk a little. I can talk a little bit about exercise and nutrition. So nutrition is not as important in lung disease as it is in heart disease or gastrointestinal disease, GI disease. But there are some associations. So it's for example, it's been shown that high fiber foods are associated with good lung health, eating a high fiber diet. And then there are also studies showing that highly processed foods, so for example, including cured meats, are associated with worse lung health. Is that kind of what you were talking about?
Yeah, just like, or like, how about like exercise? Can that have an impact on lung health?
Sure. So any aerobic exercise where you get your heart rate up and you get your respiratory rate up is good for the lungs. Other than that, I guess I would say that it's been shown that in patients with very severe lung disease, like people with emphysema or people before or after a lung transplant, exercise programs, and we often refer to these as pulmonary rehabilitation programs, can not only improve symptoms, but even slow the decline in lung function. People with emphysema or after lung transplant have a slow decline in lung function. And if they exercise and engage in, again, what we call pulmonary rehabilitation programs, they feel better. I can't say they live longer, but they feel better, and the decline in lung function that's associated with the disease is often slowed.
So there was actually a unique question that someone asked. They said, can uncontrolled blood pressure create sneezing or coughing? And are there any medications to help this?
Sneezing and coughing. So high blood pressure itself is pretty much an asymptomatic disease. It doesn't cause symptoms unless the blood pressure gets very high, or if it lasts a long time. If you had high blood pressure for many, many years, you can begin to have symptoms from it. Sneezing is not a common symptom. I've never seen a patient sneezing because of high blood pressure. On the other hand, coughing can be related to high blood pressure. And we were talking about the interaction of the heart and the lung. So if the heart is affected, if the heart is affected by lung disease, some drugs, you might have coughing in that situation. Some drugs that are used to treat high blood pressure, there are drugs, there's a whole class of drugs known as ACE inhibitors that are used to treat high blood pressure, and they can cause chronic cough. And sometimes patients will go months or years without the doctors realizing that the drug that's being used to treat the blood pressure is itself causing the chronic cough. So sneezing, I don't think so, and that would be pretty unusual.
Okay. So kind of just a question for me. So I know like that there's some like kind of like, I know you're not an infectious disease doctor, but I know that there's things like whooping cough or like RSV that primarily like affect children. Is it just because they're in like such a closed environment with like in like schools and stuff, or is it like something because they're younger?
That's an interesting question. So I'll give you an example that I know of is that we used to think that RSV only affected children. And I think it was sort of lore. You know, we had learned that in medical school, and now we know that older people get RSV as well, and immunocompromised people. And you may actually have seen these ads on television for the RSV vaccine. So I wonder if part of it is that we just don't realize that other people can get them. Other than that, I'm not sure why. I don't know why certain infections Whooping cough is a good example. You typically don't get whooping cough as a teenager or an adult. It's a disease of children. I'm not sure why. I don't know the answer.
So in your opinion, like, how do you see the future of pulmonology? Let's say maybe like in the next 10 years, like the good and the bad.
So I listed for you a couple of these new therapies. I think there's gene therapy coming for some genetic pulmonary diseases, like certain patients with emphysema, with cystic fibrosis. I think the future is very bright. There are new drugs being found all the time, these new drugs for lung cancer. I'm very hopeful. I think we're going to do very well in the next millennia.
Do you think that there's maybe like any concerns or like issues that the public might face with like changing habits or modern lifestyles that we might see more in the next 10 years?
Yeah, I mean, I was just reading an article about the likely effects of climate change on lung function. That's something we're really going to have to worry about. And maybe not so much in Philadelphia, but in poor areas of the world, in countries that are under-resourced, in Africa, for example. Many of the changes, increased storms and heat, are going to affect lung function in these areas very severely. I'm no expert, so I don't know, but that's just my guess.
So kind of like as a doctor as a whole, like how do you handle, because I know as a pulmonologist you must deal with like a lot of like chronic or like terminal lung conditions. Like how do you handle with the emotional aspects of treating
Oh
patients?
gosh, that's one of the hardest things about what I do. It's hard to give a general answer to that, but we're beginning to train young doctors to be prepared for having meetings about death and dying and limiting treatments in certain situations. I find those conversations with families and with patients among the hardest things that I do. I can't say much more than that, other than that they're difficult situations. They happen all the time. We actually, I don't know if you remember this, Priyanka, but during the summer program, we had a session on bioethics and how to talk to patients and different situations that come up. I think it's worth introducing young people, even in high school and college, to some of these situations because they're so important and they come up so often.
So on a brighter note, like what do you find most rewarding about your work?
I think I mentioned this before, but I love to teach. I think teaching young doctors, nurses, we teach a lot of nurses in some of the sessions that we do. One of the things we've been starting to do at the hospital is what are called mock codes. So I told you that I teach resuscitation practice. So for the last 10 years or so now, what we do is we have robots. These are called simulated patients. They're actually robots. We stick them in a bed. We call a code, overhead, code 99, and then we see what happens. And we teach the doctors and the nurses and the respiratory therapists and the pharmacists how to handle emergencies. I find that very rewarding and a lot of fun. And we've been doing more and more of that kind of thing.
So we actually have a question in the chat. Someone asked, does phlegm form and could you possibly choke while you're sleeping due to phlegm? And how can we identify the cause of it and treat it?
Yeah, so there are diseases where secretions themselves are a problem. Cystic fibrosis is one of them. Chronic bronchitis is another one. If the phlegm forms as part of an infection, they can be treated with antibiotics or with there are devices that are used to help clear the airways of phlegm. I think I mentioned this, there's no good drug. There's no good drug for improving secretions. In cystic fibrosis specifically, there are up-and-coming medications that may do that, but in general, in most patients with pneumonia or other diseases like chronic bronchitis where phlegm is a problem, there are no good drugs for secretions and phlegm.
Sorry, we just have one more question. Yeah. Someone asked, they said, like, how does like snoring, like while you're sleeping, could that affect the lungs, or like what does it indicate?
So there's a spectrum of diseases known as sleep apnea and related diseases. On one end of the spectrum is people who just snore. And what snoring is the airway collapsing, the upper airway partially collapsing when patients while they're asleep. It's actually a normal thing to happen. Normal people snore. As you get older or you gain weight or you have certain other conditions, the snoring, the same physiology, the same function that causes snoring, causes the airway to more completely collapse. And so on the other end of the spectrum are people with what is called obstructive sleep apnea. These are people whose snoring is so bad, it's not even just snoring, the airway itself completely collapses. And that's a dangerous situation. These people actually stop breathing or are unable to breathe for prolonged periods of time while they're asleep. There are treatments for it. There are surgical treatments for it. There's contraptions that they can use. And if it's diagnosed and these treatments are instituted, it changes their lives. They sleep better. While they're awake, they feel better. These devices are a real boon, and it's a very common problem in the VA hospital where I work. Probably 10 or 15, maybe even 20% of patients have this problem of sleep apnea, and we're beginning to be able to diagnose it and treat it much better than we used to.
On the same note of sleep, actually, someone in the chat just asked, like, if you see a little bit blood, like some blood in the morning, like when you spit up your phlegm, could that be of any concern?
So I'd have to hear more about it, but it is not normal to have blood in your phlegm. Now, if you have chronic bronchitis, for instance, people who smoke, or even people who vape and develop bronchitis, you can get blood in the phlegm from those conditions. And that's, if it happens, if it happens chronically, if it happens more than once or twice, that's something to worry about. I think you should see a doctor about that. Yes, that's not a normal thing to have blood in the phlegm.
And that's pretty much all that we have for the questions. I just, if you were able to say one thing to the public, like, what would your one message be?
You know what I'm going to say, Priyanka. What am I going to say?
Don't smoke.
That's right. Don't smoke, don't vape, and exercise. Those are my 3 pieces of advice.
Are there any specific exercises that you would recommend?
No, aerobic exercise. Get your heart rate up. Get your lungs pumping. That's what you should be doing.
All right. Well, with that, we're going to be concluding our meeting today. Thank you so much, Dr. L, for finding the time in your busy schedule. And thank you so much for such an informative session. Thank you so much to everyone else, again, for attending this meeting. If you missed anything, don't worry. The recording of the meeting will be up on my website by tomorrow around this time. And the link should be in the message that I sent you all, and I'll put it in the chat as well. But thank you so much. We're also going to have a meeting soon about endocrinology, diabetes, and obesity. So I hope you all will be able to join that as well. Thank you so much, and have a great rest of the day, everyone. Thank you.
Thank you, Priyanka. Thanks, everyone.
Thank you very much.